Are you able to see my shared screen? Yes. Thank you.
Um, I'm Dr. Ken Lippincott, and I'd like to call this meeting of the Mississippi State Board of Medical Licensure Executive Committee to order. It's 8 o'clock, and we have Dr. Michelle Owens, our Vice President, and Dr. Rod Givens, our Secretary, and I serve as President here as the Executive Committee. And the first item on our agenda this morning is a request from Emily Hill, physician's assistant. Is Ms. Hill on the screen?
Yes, yes, sir.
There you are. Thank you. Well, good morning.
Morning.
Could you tell us what you're requesting of the board, please?
Yes, sir. I'm a physician assistant. I live in Wilkinson County, which is Southwest Mississippi, rural Mississippi, and I am requesting that a waiver for the 75-mile rule for supervising physician Dr. Griffin, who lives in Jackson, Mississippi.
And what town is in Wilkinson County, Ms. Hill?
Well, my territory will actually cover 5 counties, but I reside in Woodville, Mississippi, which is just 8 miles from the Mississippi-Louisiana border in the very southwest tip, south of Natchez, Mississippi, about 35 miles.
Okay. And how many miles is that from Jackson?
It's about 2 hours.
Yeah.
Miles is probably 100 plus, 120.
And have you been working with Dr. Griffin before?
I just started with this company in June, but yes, I have been with him in Jackson in his clinic.
And could you tell us what is your company and what is the nature of your practice, please?
I'm employed by Wound Management Specialist, which is located in the corporate office is in Flowood, Mississippi. But I provide in-home wound care and primary care in rural Southwest Mississippi.
Okay.
So mobile wound care, if you will.
Okay. Um, So could you tell us a little bit about your background and education and training, please?
Yes, sir. I'm born and raised in Mississippi. I went to undergraduate school at Louisiana State University in Baton Rouge. I graduated from LSU in 2005 with a bachelor's degree. And then I went to physician assistant school in Alabama. At the time, the state of Mississippi did not have a physician assistant school. So I went to Alabama. I was there from 2006 to 2008. I graduated with a master's in health sciences, physician assistant studies. And then I moved to New Orleans and I worked at Osher Medical Center main campus from November of 2008 to September of 2022. I was a physician assistant in plastic and reconstructive surgery with wound care as well for that entire time. I was the lead APP over the surgical subspecialties. I also worked PRN in the emergency department from, let's see, June of 2018 until I left Louisiana in June of 2000, no, September of 2022. And then I was employed by Riverbridge Specialty Hospital as the director of wound care for inpatient and outpatient services from September of 22 through May of 25. And then I started with this company, Wound Management Specialist, doing mobile in-home wound care in June of last year.
Well, thank you, Ms. Hill. Thank you for that, Ms. Hill. Um, um, do Dr. Owens, are you Dr. Givens? Y'all have anything you want to ask Ms. Hill? It sounds like you have a pretty good background in wound care.
I do love wound care. Yes, sir.
Do we have is Dr. Wilkinson with us? I mean, Dr. Griffin. Is Dr. Griffin with us this morning?
Yes, I'm here.
He is.
Uh, uh, Miss Dr. Griffin, do you have anything to offer on this request?
Not much. I think she pretty much covered the majority of it, but if I can expound on kind of what the company that we work for, that we um, the type of care that we provide, we aim to serve those not only in the rural areas of Mississippi, but any of the people who have troubles with access to getting to clinics or getting places for for their wound care. And so their primary goal is to be able to bring that in home, no matter what part of the state that they're in. And so that's the largest part that Emily kind of helps us with, is getting to some of those people that's kind of in her area of the state where she lives, with seeing those people. And so at any point in time, she may travel sometimes 50, 60 miles to go see a patient in their home, uh, to help them.
What kind of wounds are we dealing with here anyway? I mean,
And so there are all kinds of wounds. There's not any just specific wound that we kind of limit ourselves to. There can be pressure ulcers, venous ulcers, diabetic foot ulcers, ulcers or wounds that result from radiation treatments, just anything that kind of comes about, surgical wounds. And so we have services that, provide in-home, nursing home, and also in the clinic. And so any patients, even that, any of you may even have, feel free to, contact us about. Um, but anybody that has any sort of wound anywhere, it doesn't matter, and we pretty much handle that in home. And if it's something that we get to and see that is something that's going to require more either surgical debridement or reconstruction or anything like that, we work closely with other subspecialties to get those referred out to and get them taken care of. We recently started a transportation end in our company to kind of assist with that also. So if there's something that has to be seen by one of those other subspecialties, and they have that trouble with access, we have transportation that can come and get them, and get them to whatever appointment that they need. So
okay. Thank you, thank you, Dr. Griffin. Could you tell us about the nature of your practice? Is it compatible with Ms. Hill's practice?
yes, so I am doing pretty much 80 to 90% wound care primarily. I'm boarded by the American Board of Wound Medicine in wound care. And so I practice in multiple hospitals in the Jackson area and the surrounding area, and also we have a clinic that's in Flowood. I have done some in-home care myself and also nursing home, so I kind of do a little bit of it all.
Wanted to know if there's any specific
Thank
verbiage
you
he
very
should
much.
use. And I told him in a nutshell
I
that,
don't know who that
you're
is,
asking
but
for the exemption.
If you are on the call and not muted, could you please mute your mics? Thank you.
thank you, Michelle. Um, Dr. Owens, um, I forgot what I was going to say. Hold on.
And when you ask.
Yeah.
So, Dr. Griffin, can you just, so I know you said you were boarded in wound medicine, but I guess I'm not really some boards are available to people who have trained in a variety of different specialties. So you can, like, for example, obesity medicine, you can come from a variety of backgrounds. What is your primary background? Like
My
what was
my
your
primary is
residency
family
in?
medicine.
Okay, thank you.
Mhm.
And what's the name of your company?
Wound management specialist.
Um, and how long have you been with them, Dr. Griffin?
I've been with them 5 years now.
And how many PAs and NPs do you collaborate with?
So there are maybe 5 or so. Then I'm secondary on quite a bit. One of my main duties that I do there, I work with quality control. So I review pretty much just about everybody's charts that works for the company in this state, just as a quality control issue to make sure that things are being done the way that they're supposed to. And I have kind of routine meetings with the different providers if there are any issues, or even if there are not any issues, just to check and make sure that people are able to get the things that they need as far as like supplies and things like that. And also troubleshoot if they are, having any issues. And so I kind of help everybody, but that's more of a quality control thing that we do, and we have a team of people that do that.
Okay, thank you. Thank you. Um, I'm a little, we've got an item in our packet here that has like dozens of PAs and NPs listed. And I was just trying to figure out what that is. It, it's
Is that what's on the on the insurance?
The insurance certificate.
insurance certificates. So is that all all these people work for
Wound management.
for wound care? Certificate of liability insurance. Yeah. We got they have a bunch of providers, and is this nationwide, or do we know?
Yeah, so the company is in 12 states,
Yeah.
and so that may list a lot of those providers that may be in other states
Okay.
also.
Okay.
And so,
Yeah.
I may. So, Dr. Griffin, so
yes.
you said that you do quality control for this company. Are you still engaged in clinical care? Are you also still seeing patients as well?
Yes.
And are those patients, are you seeing them by home visits only, or are you seeing them at a specific site?
I do a mix of it all. So I have one day that I'm in clinic, and then the other days I do hospital consults. I do some in-home, some nursing home also. And that's just mainly to kind of keep a steady lay of the land of how things are functioning in each one of those areas. And so that no matter what, I'll stay familiar with, each one of those areas in case anything arises.
And do you all collaborate, because you're in this wound care space, do you all collaborate with like plastic surgeons and other surgery specialists who might be involved or might need to be involved in patients who may have more complicated or complex wounds?
Yes, and so we work closely with Dr. Kolner at the Burn Center at Baptist. We have the surgical associates that are located in the Colonnades and Baptist. Also, advanced vein and vascular associates. Those are the vascular specialists. We use the infectious disease specialists that are at Baptist, and also in Vicksburg, who also come to Jackson. And so we have a number other physicians and the subspecialties who we work closely with.
Thank you. That's all I have.
Okay, do we
I-
have?
Yeah, I just
Dr.
had one
Gibbons.
question. Yeah, Dr. Gibbons here, radiation oncologist. Just real quick. So for your collaboration with Ms. Hill. So for example, if she sees somebody over in Woodville, and by the way, I live down in Natchez, so I'm familiar with that area. Love Clark's Creek, by the way. So
Yes, sir.
so Ms. Hill sees a patient out there that's got, whatever. How does that relationship work as far as her documentation and oversight and collaborate? Just real quick. I mean, not super detailed, but just so I can get an idea of how it would work with somewhat complicated wound that she saw.
So if there's a more complicated wound and if there's any questions about anything, one, we use FaceTime quite often where I can get an actual, look at a wound and we discuss that care with each other. And of course, we use electronic medical records to where I can always go into a chart and look at anything I need there, which we take two sets of pictures. One is just your normal photograph of a wound. We also use fluorescent wound imaging that offers us some additional information about that wound and the bacterial burden of the wound. And so we do that. And then if there's an issue that we need to, like I said, get them to a subspecialist, then we have an entire team of people that are in our main office that we can contact and kind of arrange, for that person to be able to get to one of the subspecialists. And so, like I was stated earlier, if they need to, come to Jackson to see, let's say, a vascular specialist, then our company has a transportation type thing that we can contact them and kind of arrange that transportation to get them to an appointment.
Good. All right. Thank you.
Do we have any other questions or discussion from the executive committee? Anybody else? If not, we have a request from Ms. Emily Hill, PA, for an exception to the 75-mile rule. We can entertain a motion at this time.
Move to approve the request for waiver.
We have a motion to approve this request. Any further discussion or debate?
No, I'll second.
So we have a second. Thank you. We have a motion and a second. Any further discussion? If not, all in favor say aye.
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 The request is approved, and good luck, Ms. Hill and Dr. Griffin. Thank you very much.
Thank you. Appreciate y'all's time.
Didn't sign that.
Yeah. Okay. The next item on the agenda is Dr. Marco DeSantis, who's requesting exceptions to the 2080 rule and the 75-mile rule. Is Dr. DeSantis on the screen?
Yes, I am. Good morning.
Good morning. Good morning, Dr. DeSantis. Could you tell us about what exactly are you requesting from the executive committee this morning?
Yeah, so basically, I am requesting an exception to both the 75-mile rule and the 2080 rule. I work for a company called Verta Health, and we have a very unique care model. Our mission is to help people with diabetes and metabolic disease reverse their conditions, primarily through use of a ketogenic diet along with standard medical therapies. Our practitioners are located in all 50 states, and the practitioners are comprised of physicians that are trained in internal medicine, family medicine, endocrinology, like myself, and nurse practitioners as well. We collaborate despite the fact that we all live in different places around the country. So that's kind of why I'm coming before the board today to request these exceptions.
And so are you let's see, what is your physical location,
Yeah.
Santis?
Yeah, I live in Ohio. I live in New Albany, Ohio, outside of Columbus.
And how many um uh, mid-level providers are you requesting exceptions for?
In this particular case, I believe it's only one. Her name is Kylie DeLulo. She lives in Boise, Idaho, I believe.
Okay.
But like many of our providers, we're licensed in multiple states. So
Okay. So you're located in Ohio, and
Mhm.
and where's your company located?
So Verta Health, I think, is based out of San Francisco, California.
Right. Um, and the nurse practitioner's in Idaho, right?
Correct.
Okay. And so uh, could you tell me a little bit more about the nature of your practice there? You're doing like, is this like monitoring of endocrine conditions? How do you do that?
Yeah, so we basically have a remote care model where we primarily implement a ketogenic diet to help people with diabetes, prediabetes, and obesity reverse their conditions. Um, in addition to that, we all also, practice the standard of care with medical therapies. We have, like I said, providers that are licensed all over the country and nurse practitioners that we collaborate with. How kind of our day-to-day functions is we have an in-house EMR that allows us to track biomarkers and labs. So we're looking at things on a daily basis like glucose and ketone levels to see how people are adhering to the ketogenic diet. And then as people progress, we make appropriate medication adjustments, reductions in medications in a lot of cases, in order to help people reverse their disease. So we're kind of very, very closely monitoring, these patients. So
Nice.
Yeah, sure, Dr. Gibbons.
Dr. Owens first. Okay, so Dr. DeSantis, so walk me through how this process works. We got there's a patient in Clinton, Mississippi.
mhm.
All right. How do they, first of all, find the services that you offer? Walk me through that process.
Yeah.
Patient who I guess wants to utilize the services, how do they find you, or how are they identify it?
So there are some direct to consumer, um, ways that patients can join Virta, but primarily it is through their companies that have uh, that offer Virta through the insurance policy.
Mhm.
And so through their employer, typically this is how it is. Through their employer, patients will then opt in to Virta's program because it's an offered benefit.
Okay.
And then they'll establish contact with someone from our team in order to enroll. And then once they're enrolled, then they are assigned to a provider that has a license in the particular state in which they reside. So in this case, Mississippi. They may be assigned to a nurse practitioner or to a physician. But again, there's collaboration between the nurse practitioners that have patients assigned to them as well. So that's kind of how it works. It's usually enrollment through the benefits plan of their employer.
Okay, so benefits plan, they live in Clinton, Mississippi, they would
Mhm.
potentially be assigned to the APRN that you've got in Boise, that would be assigned to patient X, or through some way, a screening or something like that, but that individual will be then seen by the APRN, who would then
Mhm.
evaluate the patient. How does that evaluation work? Can you
Yep.
describe that interaction?
So there's an extensive intake call that happens in the beginning, and that's where we, basically capture all of their important medical information so we can make sure that they're safe to proceed into the program. And then we have the ability to conduct phone and video visits with patients if they'd like. But generally, it's not like the traditional care model where you see a patient in the office, or even through, telemedicine service per se. So we're doing, pretty intensive daily remote care monitoring of all our patients. And so that way we can help them reverse their disease safely and quickly.
Okay, so but I'm just trying to figure out. So how are you monitoring?
Yeah. So our EMR system has sort of built-in features where patients will receive in the mail a monitor that they can check glucose and ketone levels. This monitor will sync to our EMR system, and so it'll automatically upload the data. And then we have a program within our EMR where it allows us to review all of these markers for our patients. And if there's patients that have markers that are outside of the accepted range, it alerts us immediately. So that's kind of one of our safety mechanisms that we have. And then if that was the case where the markers were outside the range, we have a built-in patient chat where we can message them directly. We can also call them on the phone or set up a video or phone appointment, official appointment. But generally, for the most part, we're conducting conversations through this chat mechanism for patients, and so we can kind of have ongoing discussions like in real time and make decisions quickly. So as opposed to them, saying having to make an appointment with the doctor in a week or whatever, they can, we can literally say, hey, you logged a blood sugar of 320 yesterday. What happened? What was going on last night? And then they can, then that scenario can play out and we can make an appropriate medical decision on what to do with medications or diet or whatnot.
Yeah. Hi, Dr. DeSantis. I'm
Hello.
Dr. Owens. Just a couple of questions because you said you used some terms that were a little bit interesting to me.
Sure.
As a matter of fact, one of the reasons that I went into medicine was related to diabetes. So you talk about reversing the condition. Can you help me to just clarify what that means? Because when you say reversing conditions
Sure.
in diabetes, I'm not understanding if that is supposed to imply that we're turning back the clock on your diabetes. Or are you saying that we're just going to get an improvement, like an accelerated improvement or a more rapid way to get people stabilized or controlled? I'm confused by the term because that's just not a term that I've typically heard applied to. And I know that, say, for example, with rapid weight loss and some of the other things, you can actually have people who were diabetic who have improvements because they don't have that peripheral insulin resistance and all that stuff. So, like, is that kind of what you're speaking to when you talk about reversal of their diseases primarily through a weight loss pathway? Or can you just like clarify that for me?
Sure. Yeah, so there's a little bit of, I think, debate in the medical community, and it's a bit controversial whether you use the terms, cure, remission, reversal. We use the term reversal. We also do use the term remission in some cases. For instance, let's take a patient who, say, is middle-aged, has type 2 diabetes, and is on, multiple oral diabetes therapies and insulin. So we would implement a ketogenic diet for that patient. And this happens many, many times. But through the process of implementing that ketogenic diet, we're slowly and safely reducing their medications to avoid hypoglycemia. And as they lose weight, their body becomes more insulin sensitive. Oftentimes we can, deprescribe the insulin and other therapies. And, if the patient is able to maintain an A1C that is below 6.5% without any diabetes specific medications, we consider that reversal or at least remission. We have, multi-year data showing that patients can maintain this if they adhere to the nutrition principles that we give them. So it gets a little murky, I understand, with the terminology, but essentially we're helping people reverse their metabolic disease and get off medications, which saves so much in healthcare costs, and extends their lives and improves outcomes and all those things as well.
No, I get that. Thank you. That clarification, I think, it was important, at least for me, just to kind of understand exactly what we're talking about, because I wanted to make sure that I understood kind of what it is that you're the care model that you guys are presenting, like what that's built upon, the philosophy behind it. My next question, you actually kind of is a great segue to my next question, because you mentioned that you have lots of data. And so I was kind of wondering if there's any, this is your opportunity to kind of blow your horn. Do you have like what kinds of outcomes are you all seeing, since this is a company that's in a lot of other states? Like what's your data look like as you guys have promoted this care model? How well are you doing in this area?
Yeah, no, that's a great question. I wish I had somebody from the research team with me that could give you more details on all of that stuff. I don't have it like right in front of me. We have published research on, there's some trials that you could look up from Virta. The initial clinical trial was through, I believe, Indiana University. That was our very first trial, showing that it was actually realistic to reverse metabolic disease, particularly diabetes. And then we published some other research beyond that, but from what I can recall, around a third of patients will reverse their type 2 diabetes with our program. I think in the initial trial, it was upwards of 90% of patients that were able to reduce their medications, and a significant amount of those patients were able to get off of insulin completely. So I wish I had some more specific data. I don't want to misquote numbers and whatnot for you, but yeah, we have treated hundreds of thousands of patients so far in our, I don't know, 10 plus years.
No, I appreciate that. And then next question, just if you're using remote patient monitoring to ascertain this information, based on the fact that you're encouraging a ketogenic diet, how then do you make the determination between a person who is adherent to your diet, but or at least who's been adherent? Because I guess ideally, if they're fully adherent, you wouldn't expect them to have high glucoses. But say, for example, in the setting of infection or other things that could give you abnormalities in glucose, how do you determine between a person who's just kind of doing what you asked that might have something else going on and a person who actually is in DKA? Like, do you guys use specific biomarkers in your monitoring that would help you to distinguish or differentiate between the two? Because it seems like it might be something that's difficult to ascertain, and probably even more so remotely when you're thinking about something that might be a potentially life-threatening complication for people.
Yeah, no, that's an excellent question. We have sort of a built-in algorithm, and if someone has really high glucose and ketones are above a certain threshold, that will flag, and then we will reach out to those patients and ask them what's going on. So like you said, there are other things that can pop up where a patient's on steroids, all of a sudden their glucose is very, very high, or they have an underlying infection, and despite their efforts with diet, their glucose remains high. So there's obviously something going on there. So yeah, we run into these things all the time. DKA is something that can happen. It's extremely rare on a ketogenic diet. There's a slight increased incidence for patients that are on SGLT2 inhibitors that can raise ketone levels. So doing a ketogenic diet along with those medications can increase the risk slightly. We do provide safety information. We actually have a protocol to help prevent DKA in patients that need to be on those medicines because they have underlying comorbidities like renal disease or cardiovascular disease. Safety is our like number one priority. And so again, it's nice that we have the ability to chat with patients on a daily basis. And as soon as something is flagged, we can reach out. And prevent some, negative outcome.
And say, for example, if there's a patient who's theoretically participating in this program here in Mississippi, may have a primary care doc, and their primary care doctor may be checking in on them or seeing them maybe every 3 months. It would seem like the information that you guys are obtaining through your remote monitoring might be really instrumental and valuable to said primary care doctor. Do you have a process whereby you um, share that information that you have? Is there a way that that information can be shared? Is there like transparency between what you all are doing and primary care doctors' offices for that information to be shared so that they too can have access to the information and see what's going on?
Sure. Yeah. So our clinical enablement team takes care of that side of it. But primarily what happens is when there's a medication change that triggers a note to be sent to their primary care physician that we have on file. And so they'll be notified that there's been a change. Oftentimes patients will, prefer that only their local physician, whether it be endocrinologist or PCP, make medication changes. And we totally allow that. We just ask that they keep us updated so we can have our records correct. But there is a mechanism that triggers information to be shared with the PCPs. So.
The chair recognizes Dr. Cleveland, our executive director.
Thank you, Mr. President. Dr. DeSantis, I got a little bit different kind of question I want to ask you. Have you read the Mississippi telemedicine regulations, and are you familiar with them?
I have not.
Okay. Well, you may need to know then that we don't allow non-real-time communication with the patient. So do not allow text message only. You have to communicate with them orally, either by phone or FaceTime. So I would recommend, depending on what the committee decides, that you make yourself familiar with our regulations, as well as our laws surrounding telemedicine. Do y'all use GLP-1s or semaglutides?
Yes, we do.
Are they shipped from an out-of-state pharmacy?
I don't know if I know how to answer that question. I'm not sure.
Let me ask you this. If you have a patient A in Mississippi that is obese and diabetic, and you're going to prescribe them a GLP-1 or a semaglutide, what is the pathway that happens?
Well, we ask the patients where they want their prescription sent, what's their preferred pharmacy. And I guess, it would depend on the insurance company, if it has to be mail order, then we have no choice but to send it to the mail order pharmacy, and then it ships to the patient. I don't know specifically, with my Mississippi patients where those prescriptions come from, but that's how it typically go.
And currently, FDA does not allow for compounded forms of this medication to be used. Right. So we enforce that in Mississippi. Are you familiar with that?
Yeah, and we do not prescribe any compounded, GLP-1 medication.
Okay. All right.
Yep.
Thank you.
Yep. You're welcome.
Dr. DeSantis, I see you have a practitioner agreement with Ms. DeLulo, dated back in May of last year. Have y'all been working in Mississippi yet?
Yeah, I believe we share some Mississippi patients. Yes.
So, are you? I see that you have an agreement here as her backup physician. Is that correct? Or are you her primary collaborator?
I believe it would be backup. Yep.
Backup. Okay. So you've been working with her with Mississippi patients already. And how did it come to your attention that you needed to request an exception to the rule?
Well, it was something that was our company uses a third party system that helps with credentialing and licensing matters to make sure that we stay up to date on everything. I was, I think, notified through them that this issue had come up. And then I reached out to the board to, get more clarification because I was unaware of this whole thing. But so that's kind of how it came to my attention.
How many states do y'all practice in?
We practice in all 50.
Okay.
I have licenses in, I think, in 13
And
currently.
and is Miss DeLulo your primary provider here in Mississippi, or do you have others?
You know what? I don't know offhand if there are others who are also licensed in Mississippi. I don't know that.
Do you know who her primary collaborating physician is?
Um, I believe the primary on the agreement is Jeff Stanley, if I'm not mistaken.
Yeah.
Yeah.
And where is he located,
I believe he's located around Portland, Oregon.
Okay.
I believe he's licensed in all 50 states too. I think that may be, he's been with the company a long time too. So I think that may be why he's the primary on that.
Okay. And how many mid-level providers do you collaborate with?
Phew, gosh. The company's growing so much, it's hard to keep track. I would, if I had to guess, I would say about a dozen or so.
Okay. And do you have how many states do you practice in that require physician mid-level collaboration?
Um,
Just as a, I mean, just a I mean, an idea, because how many? I'm just curious, how many states allow independent practice for these mid-level providers?
Gosh, I really don't know the answer to
Okay.
that.
Okay. Never mind. That's really not pertinent here, but anyway, well, thank you very much. And by the way, is Ms. DeLulo on the screen this morning?
No, I wasn't aware that she had to be with me,
She
but
doesn't. She doesn't.
okay, okay.
I was just asking if we don't have any jurisdiction over her,
Sure, sure.
do we have any other questions or discussion from the committee? Dr. Owens?
Not a question. I'm waiting on my motion.
If no further questions or anything else, Dr. Gibbons?
No questions. I make a motion. We close the meeting.
We'll entertain. Okay, we have a motion.
Second.
Have a motion and a second. Any discussion or debate? All in favor, say aye.
Aye.
Aye. The meeting is closed to go into closed session to consider whether to go into executive session. So we'll be back. The executive committee is back in open session, and our secretary, Dr. Givens, will read the decision of the executive committee.
Okay, the executive committee has met, and the decision was to deny the request for exemption of the 2080 rule and the 75-mile rule. Dr. DeSantis can reach out to Dr. Cleveland next week for further information.
Thank you, Dr. Givens, and thank you, Dr. DeSantis.
Thank you all for your time.
The next item for the executive committee is a request from Dr. Herman Sachs and Courtney Reeder, PA, for an exception. Do we have Dr. Sachs and Ms. Reeder on the screen?
Yes, sir. This Courtney Reeder here. Good morning.
Good morning. Who
This is
who wants to go?
Herman Sachs.
Yeah, Dr. Sachs, would you please tell us about exactly what your request is for the board this morning?
Yes, and I can also give you a short presentation to lead into what we will be presenting.
Well, our time is kind of limited, but please present what you need to present as regarding the nature of your request.
Okay, can you see my screen?
Yes.
Okay. The name of the company I'm representing is LuminaCare, and the purpose of the company is to provide virtual clinical solutions, streamlining support care. It's now in 27 states, 6 are pending. The issue is that in nursing homes and other places like that, there's problems with being able to provide continuous care. And also what you want to do is that you want to reduce the numbers of after hours admissions to acute care. And there are a lot of nursing homes that are being challenged because of budgetary constraints and other things like that. And I mentioned that in this slide. This is a patient population with a very diverse and care need that also require a lot of care and have a lot of comorbidities, as you can see. Care is suffering and costs are out of control. Here's the solution. Continuous coordinated virtual care and average rehospitalization with LuminaCare is 2%. So we use EHR, timely delivery communication care team, plan management, and then after hours telehealth, tailored management plans. And it's a coordinated care model that connects providers, processes, technology to ease burdens on the clinicians. And these are the services, and the ones are after hours telehealth, chronic care management, transitional care management is what I would do. I'm not a behavioral health specialist. So the important thing in this slide, 8 to 9% reductions in ED visits. And so the issue is to escalate and act and to provide hands-on care or through a telehealth model and support that starts before patients change settings. And the goal is these patients are in nursing homes. They need to get more follow-up care than what they're currently getting. Just to give you my background, I've done geriatrics and extended care for 16 years now in the federal government. I've come across all these problems. One of the biggest problems in my day job that we do is that we have a significant number of nurse practitioners and mid-level providers that we use to continuously monitor the patients while they're in the nursing home setting or long-term care or transitional care setting. And we provide the continuity of care that keeps them from going to the acute care settings and reducing that burden. And I would work with the NPs and PAs that are associated with Lumina Care to carry out our mission of increasing quality care as well as reduction in acute visits to the emergency room, which has its own set of problems.
So you're requesting an exception to the 75-mile rule?
Yes, sir.
And how many mid-level providers are you requesting exceptions for, Dr. Sachs?
We are looking at 9 at this time.
And are they all nurse practitioners except for Ms. Reeder?
Yes, the rest of them are nurse practitioners. She's the only PA.
Okay. And so do these mid-level providers, are they on site at the nursing homes, or how do they evaluate these emergencies in the middle of the night?
They would be doing it through the telehealth model, and I can let Miss Courtney talk about that.
Yes, Ms. Reeder.
Absolutely. So basically how it works is we are considered after hours. So when the day in-person provider goes home at 5 o'clock, us APPs cover. If there is an issue, let's say for example a fall or anything, the nursing staff will call us through their iPad and in real time walk us to the patient's room, and we will evaluate the patient through the iPad, and we'll instruct the nurse, like if we need to get listen to their lungs, we'll instruct the nurse, put your stethoscope here, or whatever. And then we will evaluate and then make a decision or an intervention based off of that. We put our orders in, we looked at the charts. It would be the same as if we were in person. The only difference between us as an in-person versus not in person is that we're seeing the patient through the iPad.
Thank you. Does the executive committee have any further questions for Dr. Sachs or Ms. Reeder?
So I have one. This is Dr. Owens. With respect to, you said when the on-site person leaves, so is there not like, what do you do or how does that work in concert with, say, for example, facilities that have call systems? So say, for example, the physician may not be on site, but that person is on call. Is that individual also made aware? Are you guys in lieu of that? Or is this service considered to even potentially replace an on-call physician for these facilities? How exactly do you function? Because the presentation said that you're in a lot of different places. So how exactly do you fit or function in the model?
So, I will try to answer this as best I can. So after we see the patient, we'll put in the note as if, like we've seen the patient and everything. I don't know, exactly if we're replacing the on-call model, but what I do know is that if we're covering at 2 a.m., they're calling us instead of the in-house providers. So they have the facilities, each facility that we cover, they have contracts with Lumina, and we are the ones that are basically the on-call on-call off-site providers that are covering those calls at 2, 3, 4 in the morning, as opposed to their in-house providers.
And so,
go ahead, sorry.
No, that's fine. I guess what I'm trying to figure out. So I know you've walked through kind of what would happen, but And I will just in transparency, I'm an OBGYN, so phone calls at 2 o'clock in the morning are things. But if somebody calls you, you can instruct a nurse to do a physical exam. If somebody calls an on-call doctor, an on-call physician can instruct a person to do a physical exam because neither of you are physically there. And anything that you ascertain, but for what is done through an iPad, is information that's going to be ascertained through a third party person, right? Is I just want to make sure that I'm understanding
Yes.
the difference. Okay, thank you.
Sorry, and I also I'm a contractor for Lumen Care.
I'm sorry,
And
we can't quite hear you. Who is this?
oh, so my name is Christy. I am a contractor for Lumen Care. Can you hear me?
No, your speech is garbled.
Are you able to hear me now?
Yes.
Okay. So I just something to add. So additionally,
could you please identify yourself?
yes, my name is Christy Bondi. I am a contractor with Lumina Care. And I work with them on their compliance. So just something else to
Are you a healthcare, are you a licensed healthcare professional?
I actually am a licensed PA.
Oh, okay.
I'm not practicing clinically with Lumina Care, but I am a PA.
Okay.
So just something to add. So essentially, I think what happens too is that these providers now essentially they'll be spending about 10 hours a month seeing patients in Mississippi. And so because they're licensed in a few different states, they can work with multiple facilities and take those cases in. And so it's not the same as needing to have like one on-call physician for every facility. So it is somewhat more efficient for the SNFs as well.
So then am I hearing you correctly that you're one of the ways that your organization functions is an alternative to having an on-call healthcare clinician in the facility?
In the facility, yes. And then if there
I
are,
guess that was inappropriately said in the facility because I don't mean like like you can be on call and not literally be in-house. But so the question, just to clarify, so that I'm asking you a fair question, is in lieu of an on-call clinician.
yes. And then if there are any issues that need to be escalated, both that on-call clinician for the facility and Dr. Sachs are notified.
But if there's no on-call clinician for the facility, then what's your process?
I believe there's always still an on-call medical director or physician for the facility that is escalated to.
Correct.
Because they're the ones that are actually able to see the patient in person if need be.
Thank you, Dr. Owens. And thank you, ma'am. What's your name again, please?
Christy Bondi.
It's Bondi. So
Yes.
how many states does Lumina operate in?
They're currently in 27 states.
And ma'am? Yeah. And so Dr. Sachs, are you where is your primary practice is in Biloxi, is that correct?
Yes, sir.
And what's the nature of your practice, Dr. Sachs? You said you're in geriatrics.
Yes, that's what I do full time. And I manage a number of NPs. I do my own clinical work on geriatric patients, management, and operational control of my area of expertise, geriatrics and extended care.
And you're in you meet the requirement to practice over 20 hours a week with patients.
Yes, sir.
Clinical. And you're aware of all the rules. You meet monthly chart reviews and quarterly meetings.
Yes,
Yeah. Do we have
we have exceptional backup and management in this automated processes that are involved in that, or let's just say that it's quite comprehensive, not necessarily automated.
Okay, thank you. Thank you, Dr. Sachs. And
So I've got a question.
Dr. Givens.
Yes, so Givens here. The acceptance of 75-mile rule question would be, so the facilities that will be covered, what distance are they, or where are they located? I guess in relation to, Dr. Sachs, you're in Biloxi, so the other facilities, where are they that the coverage is asked to be provided?
Yeah, I can share a list with you, but one of them is in Meridian, and then there's Greenboro
Lauderdale
Health.
County.
Yeah,
Go ahead.
I could actually put it into the chat too, if that's helpful.
So I heard Meridian, and where were the others?
I'm just entering all of them into the chat, but I don't know the exact town that they're in. I can or county that they're in. I don't live in Mississippi, but I can look into that and let you know. But sorry, I'm just trying to send these. So these are the names of all of the facilities.
I can't see it. Read it out. I can't see it.
It's Greenboro Health and Rehabilitation Center, Middleton Oaks Health and Rehabilitation, Starkville Manor Healthcare and Rehabilitation, the Oaks Rehabilitation and Healthcare, Hilltop Manor Health and Rehabilitation, Grand Trace Health and Rehabilitation, Courtyard Health and Rehabilitation, Cass Christian Health and Rehabilitation Center, Coastal Health and Rehabilitation Center, Ocean Springs Health and Rehabilitation Center, Pineview Health and Rehabilitation Center, and Arabella Health and Wellness of Meridian.
Sounds like the furthest north might be Starkville.
Yes.
So say, for example, this waiver is granted, you guys are going to provide coverage overnight for all those facilities simultaneously?
Yeah, so we have multiple providers. Courtney is the only PA, but there are 8 nurse practitioners as well that would be practicing, hopefully, in Mississippi.
Well, I understand that there are 8 people, but that's 8 people covering 7 days, right? So, I mean, everybody's not going to be working the same day, and there will be people on vacation and other things. So, I was just trying to wrap my head around the how it's going to work, not just the theoretical component, but like how it works practically, right? Because if you have a core group of 8 people, like I have 6 partners, we don't take call on the same day. We're not all on call at the same time. And there are 6 of us, and we're still struggling to cover all of our responsibilities. So, and I presume that this is just the core people that will be responsible for Mississippi, though?
Yes.
Yes.
And they get generally like 10 hours of calls for Mississippi. Well, that's what they're expecting based on the volume that the SNFs have provided. They're expecting about 10 hours of call in Mississippi per provider, like every month. So that is, if that number were to increase, then we would definitely need to staff more and have more providers available. But considering the expected volume, we feel that 8 providers is sufficient, or sorry, 9 providers is sufficient.
That's 90 hours a month.
Okay. Any other questions or discussion from the committee?
Just to be clear, that's 90 hours a month across 9 providers. It's 90 hours a month per provider.
No, I did the math. Yeah, that was where we came up with 90. You said 10 hours per provider with 9 providers is 90 a month.
Mm-hmm. Great.
Okay, well, thank you, Dr. Sachs and Ms. Reeder and Ms. Bundy. And any additional discussion? If not, we can entertain a motion.
I make a motion, we close the meeting, consider to go into executive session.
Okay,
Second.
we have a motion and a second to close the meeting. All in favor?
Aye.
Aye. The meeting is closed to consider whether to go into executive session, and we'll be back. back in open session. And our secretary, Dr. Givens, will read the decision of the executive committee.
Turn on. Okay. Yeah, good morning. The executive committee met, and the decision was to deny the exception to the 75-mile rule. You can follow up with Dr. Ken Cleveland on next week for any further details or questions.
Thank you, Dr. Givens. And thank you, Dr. Sachs and Ms. Reeder. The final item on the agenda for the executive committee this morning is a request from Dr. Brandon Shepard and Dr. John Touliatos, I believe. They're requesting an exception to the 2080 rule. Do we have Dr. Shepard and Dr. Touliatos on the screen?
Yes. Dr. Touliatos here. You pronounced that very well.
Thank you. Thank you. Could you tell us the exact request that you're making?
Yes, we were wanting exemption for the 20-hour a week rule, as we have physicians that are going 1 day a week to the office in Olive Branch, Mississippi, which is about an 8-hour day. And we have 4 different physicians doing that, but just one day a week. And then we also have 3 nurse practitioners that are seeing patients at that facility as well. So there's, like, for instance, the nurse practitioner that I supervise is going there 1 day a week as well, but in a day different than I'm going there. But I'm just spending 8 hours a week there, but I'm doing it every week.
And where is your primary practice location?
Yes, sir. Our primary practice is in Germantown, which is exactly 11 miles away from our Olive Branch office. So it's very close.
And so do you not practice 20 hours a week?
Oh, we do, but just
not
not
in
Mississippi office. Yes.
I see. I got you. Okay. Well, thank you for that. Does the executive committee have any other questions?
Again, the nature of the practice, I've missed that. I'm sorry.
Ear, nose, and throat.
Is it general ENT or is it kind of like
It's general ENT.
Okay.
It's general ENT, yes.
Dr. Touliatos, if I may, I think I heard you say that there is a physician in the clinic 4 days a week. It's just not the same physician. So you don't meet individually, you do not meet the 20-hour rule.
That's correct. That's correct. Cumulatively, we would. I don't know if that's possible, but individually, that's correct.
All right.
So have you been practicing this model already?
Well, in Memphis, we have a couple of locations separate, but no, this is our first time. There was a practitioner that retired in North Mississippi, and I think he kind of reached out to us to maybe pick up his lease. And we've been talking about wanting to expand because we have a lot of patients that come from North Mississippi, and they always are saying, we wish I had a location closer. And so we got licensed in Mississippi over the past, 18 months, and then we established it there I think we're now 6 months into this.
So does the NP there, has he been working in your clinic already?
Yes.
And have y'all been collaborating with him, with the chart reviews and quarterly meetings?
Correct. Yes.
So how did it come to your attention that you needed to request an exception?
Brandon, do you know exactly how? My business manager told me that.
Okay.
Yeah, the same. I'm not sure, Bruce, do you have an answer to that?
Yeah. Hi there.
I'm Bruce Fetterman, MD. I'm the president of Mid-South Ear, Nose, and Throat. And when we were doing our due diligence to set up the office with some nurse practitioners, we checked the AMA website, the State of Tennessee website, our malpractice website, the Nurse Practitioner Association websites, and of course, State of Mississippi website. And we never really ran across the 80-20 rule. And when we apparently when we set up our nurse practitioners and whatnot, since we live so close, i.e., we are less than 75 miles from Olive Branch, apparently it didn't trigger the response that was needed to then have us upload the exceptions and whatnot. And so we had to talk to Jonathan Dalton on multiple occasions and actually have him, because it never quite worked properly, have him work through how we would actually submit what was needed. And we finally got that done. And that's why we were also kind of asking for permission to have been working temporarily till hopefully we would be granted approval. But anyway, I hope that made sense.
Yeah, thank you. So do they have an exception, Dr. Cleveland?
Yes, they do.
Okay, thank you. Do you have any other questions from the committee? So we've heard from Dr. Touliatos. Do you have anything to add, Dr. Shepard?
I do not. I think, as Dr. Touliatos mentioned, these are patients we're already seeing. They're already coming up to our Germantown office. We're just offering the ability for them to be seen in North Mississippi and to expand our practice there. And so our nurse practitioners help us to do that in a timely fashion for those patients. And I appreciate your time and consideration of this.
Thank you. Could you tell me what procedures do these nurse practitioners do?
Well, they're generally seeing the patients, routine ear, nose, and throat exam visits. And then if there's anything that requires a procedure, they'd be referring them over to us. I would say probably the most extensive, quote unquote, procedure that they do would be, an in-office endoscopy exam of the sinuses or the throat. But that I don't think any of them do anything beyond that.
Okay, thank you. Any other questions from the committee? If not, we can entertain a motion.
Move to approve the request for waiver.
We have a move to approve. Do we have a second?
Second.
Okay, we have a motion and a second. Do we have any further debate? We can, if not, all in favor of approving the motion, say aye. Aye. The request for the exception is approved. Thank you very much, Dr. Shepard, Dr. Touliatos.
Thank you very much.
Thank you all. I appreciate it. Have a great day.
The last item of business before the executive committee this morning is a report from the executive director.
Thank you, Mr. President. So I've continued to meet with the other health boards. This has started paying off more and more, the relationship that we developed with each other over the years of meeting once a month and getting to know each other. Most recently, we are planning some additional meetings to help both the dental board and the board of pharmacy with some issues regarding the Physicians Health Network. I met with 2 licensees over potential violations for the Medical Practice Act. Participated in the administrators in medicine roundtable discussions. And we met with the OLRC, who approved rule changes concerning CME that the board passed a few months back. That's all I have.
Okay, thanks, Dr. Cleveland. Any further business for the executive committee this morning? If not, thank you very much, and the executive committee is adjourned.